Perfect. So I just want to welcome everyone this evening. Thank you so much for joining us. It's really great to have you here. A big welcome to everyone who is joining us on the Blood Cancer UK Facebook page, and also to those joining us on the Anthony Nolan Facebook page. This is a joint event run by both charities, and we're really pleased to be hosting this together. I'm just quickly going to introduce our lovely panel. My name is Rachel and I'm the Research Communications Manager at Blood Cancer UK, and I will be your chair this evening. We are joined by Dr. Graham Collins, who is a blood cancer consultant at Oxford University Hospitals and researcher at the University of Oxford. He specialises in lymphoma and is also currently leading research exploring how different types of blood cancer might affect someone's level of risk from coronavirus. We're also joined by Dr. Teresa Inkster, who is a consultant microbiologist at NHS Greater Glasgow and Clyde. She herself has non-Hodgkin's lymphoma, and as a result of her job as a doctor and being affected by blood cancer, she has received the first dose of the Pfizer COVID-19 vaccine. We're also joined by Professor Ed James, who is a professor in cancer immunology at the University of Southampton and is a member of the British Society of Immunology. He studies how foreign bodies, such as viruses and bacteria, are presented to our immune system and how our immune system reacts to them. And hopefully, a little bit later, after he's done a media interview, we will be joined by Professor Jeremy Brown, who is a clinician scientist in respiratory medicine at UCLH, and is also a member of the Joint Committee for Vaccination and Immunology, the JCVI you might have heard of, and he will be able to answer some questions on vaccine prioritisation. Please kind of leave your questions in the little chat function below on Facebook, and I'll be monitoring them. If you see me look left, it's because I'm having a look at them, and we'll try and answer as many as possible. And just a little note that we are unable to kind of comment on individual circumstances according to diagnosis, and if you have any specific questions about kind of your condition and the vaccine, that you should speak to your clinical care team, but we will try and answer as many as possible. And the other last thing to mention is, if we don't get to your question today, don't worry. We have a fantastic support services team who will kind of monitor the questions and will make sure that any that don't get answered are answered at a later stage. So that's kind of the housekeeping I've got. And I think, if it's all right, I would like to kick off with Teresa, who has non-Hodgkin lymphoma and has received the first dose of her vaccine. And I kind of just want to ask how it went, Teresa. How are you feeling now you've had the vaccine?
It went very well. So I received the vaccine in mid-December because of my underlying diagnosis of lymphoma, but I'm also a healthcare worker. So I had been working from home since March, and I received the vaccine really with a view to try to get me to return to work. The vaccine itself went very well. I expect, like a lot of blood cancer patients, I was quite anxious about attending a busy clinic for a vaccine because I'd spent such a long time working from home and shielding for most of last year. But actually, when I got there, I was really reassured by the process that they had in place. I was able to select an appointment later in the day when it was quieter. When I got there, they obviously thought very carefully about the flow of people through the clinic, to avoid people mixing. So there was a separate entry and a separate exit, which meant you didn't come across anyone else in the corridors. And through the whole process, there was minimal interaction really. I only spoke to a receptionist who was behind a screen and the nurse who gave me the vaccine, and they were both wearing masks. So I actually felt very safe at the end of it. The actual vaccine itself was relatively painless. It was just a skin prick. It took about 10 seconds in total. And then I was asked to wait for 15 minutes just to observe for any side effects or reactions. And then I was able to leave through that separate exit after that. So it was a very positive experience for me, and I did feel really safe. And my anxieties about attending a busy clinic, I hadn't need to be anxious about that.
That's really good. Ooh. Sorry, I think that was me. That's really great to know, and I think that will ease quite a lot of anxiety for people, because I know there's a lot of worry about going into somewhere busy with rates so high. So that's really great to know. I'm going to come to kind of some questions that we've had submitted previously first, and I'm going to try and cover kind of the big ones, the big questions on lots of people's lips. So the first one is, how will we know if the vaccine is effective for people with blood cancer? Will an antibody test show this? And I guess Graham and Ed, you're probably best to come to for this question.
Sure, I can have a stab. Yep. I mean, I think ultimately we don't know when you've had the vaccine if it's going to be effective. There is the possibility of an antibody test for some, but my understanding is that the availability of that antibody test does vary from place to place. And the other important thing to know is that there are two different types of antibody test. And in fact, the one that's most routinely available now doesn't look at antibody to the spike protein, and that's the antibody that you would expect to appear after you've had a vaccine that is, the vaccine is using the protein for that spike protein. So that's the sort of catch, is that you've got to make sure that the right antibody test is done. But I think the big caveat to that, though, is if the antibody test is positive, the anti-spike antibody test is positive after the vaccine, you don't know how long it's going to stay positive. And also, how well that correlates with immunity is a little bit open to debate, particularly in patients that may have impaired immune system in other ways. But also if it's negative, so if you haven't mounted an anti-spike antibody response, there may be other components of the immune system which are providing some protection, such as T cells, which we can't really readily measure the T cell response after a vaccine. So I'm not saying you shouldn't have an antibody test. Certainly in Oxford, we've got a relatively easy access to antibody tests, and we're quite keen for patients to have an anti-spike antibody test afterwards, but we're very much using those caveats that when we discuss that with patients. It's really sort of for interest to see, are there patients who are particularly not mounting an antibody response that we can identify. But whatever happens, we will all still have to obey government guidelines about socially distancing, wearing face masks, etc., even after the vaccine, even if there is an antibody response that's detected.
That's great, thank you. And just to kind of add to that a little bit, we also do know of some studies that are going on kind of across the UK and wider which are going to look at this question specifically. So we know that Public Health England are planning a project to kind of look at people with blood cancer and other immune deficiencies to see how well they respond to the virus. There is a study going on in Germany, run and funded actually by Pfizer, to look at how the vaccine works in people who are immune compromised, and the kind of various other studies up and down the country going on as well that we'll kind of like keep you informed of as and when we know more. There's also a link, I think hopefully pasted and at the top of the little Facebook chat, and that is a link to a government NHS page where you can sign up to be part of coronavirus research. And that includes studies that some of you might have heard of, like the AstraZeneca study that is looking at how other treatments that don't involve vaccination work for people with blood cancer, and whether that gives people immunity. So if you sign up to that link, you can sign up there if you're interested in being part of research that way. And if you kind of do want to talk through anything to do with clinical trials, we have a clinical trials nurse at Blood Cancer UK, and you can email her at trials@bloodcancer.org.uk. The next question is an interesting one, and it's, will I still have to shield after the vaccine? And I guess Graham again, or Ed, would you like to answer this one?
I'll let Ed go for this one.
Thanks. I think, following on from what Graham said in the previous answer, I think, if you've had the vaccine, you still need to shield, because one, if you're not having your immune system monitored to check that you've got the antibodies, and even if you are positive for antibodies, it doesn't necessarily mean you are protected from a coronavirus infection, so the COVID infection. So I think, yes, you would still need to shield, at least until we're at a point where we can confidently say that if you have evidence of these antibodies or other immune components that we can show, then we would then have confidence that you would be immune to COVID infection, or at least not necessarily stop you being infected with the virus, but at least if you have much milder symptoms.
Yeah, absolutely, that makes sense. So what we know at the moment is that, yes, you will likely continue to be asked to shield until we kind of have a better understanding of how effective the vaccine is. And of course, we've got a lot of people to vaccinate as well. Next question. We've had quite a few questions come in about allergies, actually, saying I have a history of allergies. Will I be able to have the vaccine? And I wonder if it's all right, I think I might take this question if that's all right. So initially, when the vaccines were started to be rolled out, we did see some severe kind of reactions to the vaccines. Now, obviously, it's not good that they happen, but it is completely normal that we start to see kind of some of these rare events, because although the trials took place in, you know, groups of 20,000, 40,000, it's a much kind of different picture when you get out into the general population. So when we saw those kind of adverse reactions, initially the advice was that if you have a history of severe allergic reaction, you shouldn't have the vaccine, and that was to anything, whether that be banana or fish or anything like that. But the guidance has now changed, and the guidance now is that if you have a allergy to any of the ingredients actually in the vaccine, and the ingredients are all published online and the people giving you the vaccine will know the ingredients, if you're allergic to any of those, you can't have the vaccine, but otherwise you will be able to have it. So we had a few specific questions about particularly antibiotics, particular cancer drugs, but we think they will be okay as long as you're not allergic to any of the specific ingredients in the vaccines. Another common question we got, which is kind of one that's kind of come to fruition over the last couple of days, and it's will waiting for a longer period of time between each dose of the vaccine, dose 1 and dose 2, have an impact on the immune system? Ed, would you like to answer this one?
Thanks. So essentially, if we look at the Oxford vaccine, the most recent one that's been approved, in part of their clinical trial, they did look at extending the time between the 2 doses. And so whilst obviously initially it was 4 weeks, they also had a cohort, relatively small cohort, but a cohort of people who were immunized at a much later interval, so somewhere between 8 to 12 weeks. And they actually found that the immune response in those individuals was stronger than when it was done at a much earlier stage. Admittedly, though, we can't take too much from that because it was a smaller number of individuals that were in that trial, so it's difficult to extrapolate to say that for the whole population. But at least for the Oxford vaccine, we can relatively confidently say that we don't believe the extension to the 12 weeks will make any real difference. In fact, it may be that we induce a stronger immunity. And essentially precedence for that is if you look at other vaccines that we commonly have either through childhood or adolescence, where if we require a booster, that booster is taken many, many months, if not years, after the primary immunization, so that, you know, extending this to 12 weeks shouldn't really have a huge impact, and may even have a beneficial impact on the actual immune responses that you induce to give you protection against COVID.
That's a really great answer. Thank you for that, Ed. And hello to Professor Brown, who has just joined us, hot off the press from an interview. As I said earlier, Professor Jeremy Brown is a clinician scientist in respiratory medicine and is a member of the Joint Committee of Vaccination and Immunisation, so is involved with things like the vaccine prioritisation list. Jeremy, I might just go in at the deep end and might give you a question straight away. And it's one that came in prior to the event, and it was asking, you know, if I'm vaccinated as someone with blood cancer, why is the person living with me who doesn't have blood cancer not vaccinated? Surely they get it too. And I wondered if you could address that question.
Okay, it's a slightly tricky question. We debated this quite a lot. The main issue is that there are no data yet on whether the vaccine prevents transmission. So you could be vaccinated, you might get asymptomatic disease rather than symptomatic disease, not know that you're infected, but still be able to transmit to others. So what the vaccine does is it sort of downgrades the clinical level of infection you get, but it may not stop you from infecting your nearest and dearest. So without those data, it's hard to use a sort of what you might call a ring vaccination. It's not quite the right term for it, but to sort of vaccinate the contacts of somebody who's at risk. And the protection you get from the vaccine is actually much better than we were really expecting. And even in somebody who's immunosuppressed to a degree, there should be a reasonable level of protection and that is likely to prevent them from getting serious infection. I mean, there are some people who are really immunosuppressed where it's a bit more difficult, but actually most people, even with blood cancer, their immune system is competent enough to induce a response to the vaccine that will be protective, we believe.
Thank you. That's a really helpful answer. I've just seen someone ask in the Facebook comments, is this information for both vaccines? And yes, we're kind of talking quite generally here about the Oxford vaccine and the Pfizer vaccine and other vaccines that will come through.
At present, there is no difference in the way we treat either vaccine, essentially.
Yeah. And Jeremy, we were just talking about the news that came out a couple of days ago that the gap between the first dose and the second dose of the Pfizer vaccine has been extended. Mm-hmm. Now we know kind of there's some data, Ed kind of spoke about it to us, that, you know, there's data for the Oxford vaccine that the 12-week gap could actually, in fact, maybe even improve the immune response. But there's a question that's come through about the Pfizer vaccine. Is there any data on that, and why was that decision made?
So that decision was made because at the moment we're going through, as everyone knows, an absolute tsunami of cases. And what we absolutely have to do is protect as many people as possible in as short as time as possible. And it turns out that both vaccines have very good efficacy after one dose. So if you look at the data and drill down into it for the Pfizer, in the period between the second and third week after the first vaccination, you get 90% protection against infection occurring. Now that 90% protection that is present after the one dose of the vaccine in that 1 week gap before they get the second dose would not have faded if they didn't receive the second dose. It would still be there and would fade slowly over a period of time. So that 90% level of protection suggests that actually an individual given one dose of the vaccine will be protected for a reasonable period of time. 3 months is, I think, what we feel that will be maintained for that period of time. And that allows us to essentially double the number of people that we can protect in a period of time, which is just, I mean, the overwhelming need for the country is that. The second dose, think of that as really the booster that prolongs the duration of protection. So although the first dose will protect you for a good period of time, the actual prolonged duration of protection is almost certainly going to require a second dose. So we're not saying don't give the second dose. We're saying we can hang on a bit, vaccinate lots of people with the first dose, then come in with a second dose to make sure that their protection levels are maintained. And that is true for both the Pfizer and for the AstraZeneca vaccine.
That's a really, really helpful answer. Thank you, Jeremy. I'm just having a little scroll through the Facebook comments, and we've had quite a lot of questions from people who are either thinking of, well, are either undergoing stem cell transplants or are post stem cell transplants, so 3 to 6 months a year. And I guess there's kind of two questions in there. The first is for people who are undergoing stem cell transplant and have just started chemotherapy. Should they have the vaccine beforehand, or is it better to wait afterwards? And the other people who are post-transplant, at what stage and what kind of time is it appropriate to give them a vaccine? And Graham, if I give this question to you, I can help you out as well if you need, but yeah, you go for it.
Yeah, I mean, we've discussed this quite a bit within our sort of transplant team in Oxford, and there is also some national guidance. The thing about stem cell transplants, there's 2 different types, and they're really different procedures, although in the national guidance, they're all merged into one, which I think is actually very unhelpful. But because the first procedure is an autologous transplant, which is just strong chemo, that's all it is, and the stem cells just support your body going through it. And in fact, we didn't used to revaccinate. So nowadays we revaccinate people with their childhood vaccines after either type of stem cell transplant, but we didn't used to do that for autologous. And I must say, I never saw measles, mumps, sort of childhood illnesses emerge in those. We do because that's the sort of national guidance. Allogeneic transplants, they were very different. That's when you get a donor immune system growing in your body after you've had the conditioning chemotherapy. And that's a very different thing because you've got a very naive immune system there growing that's not used to working with your body. So they're very two different types of stem cell transplant. What we've decided in Oxford is that actually for the autologous, we would be perfectly comfortable with people being vaccinated for whatever, flu, COVID, as early as 1 month afterwards. Now that's earlier than most of the national guidance. I think most of the national guidance is suggesting 3 to 6 months. For allogeneic, I think you do have to wait a bit longer because it's going in too early when you're on active immunosuppression, as you often are, to prevent complications of allogeneic transplants. You probably do have to wait longer. And I would have thought at a bare minimum, it's 3 months. And that's what we've sort of been going with in Oxford. So if you've just started, and you're literally having your conditioning chemotherapy, then sure, I don't see there's any point in being vaccinated. It almost certainly won't work at that stage. Plus, you'll be, in hospital, in a side room, in pretty strict isolation nowadays in hospitals, unfortunately, with no visitors. So you will be very effectively shielded during that time. I wouldn't recommend it if you've literally just started the stem cell transplant.
Thank you, Graham. That was a really comprehensive answer. We've had some questions come through about specific treatments and how specific treatments will kind of affect someone's response to a vaccine. So in particular, we've got questions on TKIs and other medications. Graham, it's probably a good one for you. Can you think of any issues with any particular treatments people are on?
Yeah, so I mean, the first thing to say, I guess, is we are actively looking at this. So there is this big project in the UK called the UK CCMP, so the UK Cancer Coronavirus Monitoring Project, where anybody with cancer who has a PCR positive test for COVID, so is positively diagnosed with COVID, the data is getting fed into a central database. So we can try and understand risk factors for patients with cancer, and we're collecting their treatment data. So what treatments have they been on just before getting COVID? Now, there are various issues with this sort of analysis, so I can't claim to know all the answers yet. But one of the things we're most interested in looking at is some of the B-cell depleting agents, so rituximab. And the reason we're interested in that is people who've had rituximab, they've often had it for lymphoma, and they often have very low antibody levels. So they're what's called hypogammaglobulinemic. So they have low antibody levels anyway. And sometimes when you challenge them with vaccines such as flu or other vaccines as well, tetanus, there is some data that at least a proportion of those patients don't respond as well to patients who haven't had rituximab prior. Now, so far in our analysis, we're not seeing that prior rituximab, at least within the prior 4 weeks, doesn't seem to be increasing a patient's risk of death. That's what we're looking at if they get COVID. But there are caveats around this data, and it's still a work ongoing. But at the moment, that seems reasonably safe. And it's fair to say as well that other agents that have been looked at, so for example, there was a very big European collaboration looking at myeloma patients and some of the specific treatments they've been on, and it's not actually identified any particular treatments as being relatively high risk. And actually one very reassuring thing that's come out of the whole UK CCMP database is that recent chemotherapy for cancer in general, so not just blood cancer, but any cancer, breast cancer, prostate cancer, surprisingly didn't seem to increase the rate of poor outcomes in cancer patients. Probably the most, well, age is always the massive risk factor. Older patients do worse, whether you've got cancer or not, but also uncontrolled cancer, in particular, uncontrolled, untreated leukemia, myeloma, etc. That seems to be a bigger risk. So actually not having treatment and having uncontrolled cancer is probably worse. It's not to say if you're on watch and wait, you'll do particularly badly, because that is still controlled. It's not running away with you, but it's more when people have a newly diagnosed blood cancer that you would otherwise go in and treat. If a patient gets COVID at that point, that's when the outcomes do sadly seem to be particularly bad.
Thank you, Graham. Now I'd like to just come to something that Teresa mentioned earlier, and we've actually had a couple of questions about it in the comments. And Teresa, am I right in saying that your healthcare team kind of said there's no guarantee that you'll have the same vaccine first, second dose?
Yes, that's correct. They have said that they will endeavour to make sure we do get the same vaccine, but there might be situations where we get the alternative vaccine. So obviously that was something, being a blood cancer patient, I was concerned about what effect that would have, having a different vaccine with a potentially different mechanism of action. Would that impact on the immunity?
So, Jeremy, I think that's
okay. So first off, the aim is to give the same vaccine. It's only exceptional circumstances that you might get the different vaccine. Secondly, there are studies going on with heterologous regimens, giving one vaccine then another for the booster. And theoretically, it probably wouldn't make too much difference as the antigen is the same, and that's what the antibody, that's what the immune system will recognize. So the delivery system is different, but the actual antigen that's being stimulating the immune response is the same spike protein. Not exactly the same, because there's 1 or 2 little base pair changes that have been made, but essentially it's the same antigen. So it should be just as good. And there is a theoretical possibility it'd be better as well. So,
thank you. That's really helpful to clarify. I'm going to come to another question that I had pre-submitted, which I actually think is a really interesting one. Probably most likely for you, Ed. And it's someone who has CLL, but is in watch and wait. So they're not actively having any treatment at the moment. They're kind of just watching and seeing how their cancer develops over time. And they said they're a little bit worried about getting the vaccine because they're worried that the vaccine might actually wake up their immune system and cause problems. And I wondered what your thoughts were on that, Ed.
So I think from understanding how the immune system works and how the vaccines will work, I wouldn't imagine any real instance where you could wake up a cancer in that sense, because of the way the cancer has evolved, the way it has developed. And so the way the vaccines work is to obviously stimulate very specific parts of your immune system towards a very specific antigen. And so it's not that all your cells of the immune system will react to the vaccine. There's only a certain number of them that have the ability to recognize this spike protein, this antigen that's being presented in the vaccine. So it's unlikely, highly unlikely, that the cells that may make up part of your cancer are actually going to be reawakened by a vaccine at all. In fact, it's, you will have hopefully a normal immune response to the vaccination, and it won't cause any reawakening whatsoever.
Thank you. That's really helpful and reassuring. Oh, go on, Jeremy.
Well, many patients with CLL will get the routine flu vaccine every year, and there's been no evidence of that causing a CLL reactivation or awakening type situation. So I think, it's not an issue.
Yeah. So good point, and very, very reassuring as well. So thank you both for your answers there. We've had someone who's just kind of asked us to clarify on how you think patients will need to shield after the first and second vaccine jab, and how long for, and to what extent. And now, of course, these are sort of questions that we still don't fully know the answers to, because we don't know, how long it will take to vaccinate everyone. And essentially what we need to see before anything can change is the rates to go down, because they are exceptionally high at the moment. I wonder, Jeremy, if you have any other...
this is actually an incredibly important point. If you've been vaccinated, you still have to shield and carry out the same whatever restrictions the government have suggested are necessary for where you live. It doesn't change that. What the vaccination would change is eventually, when enough people have been vaccinated, then it will allow the sort of social measures to try and prevent protection to be potentially relaxed. But that won't be happening until the vaccine has been given to a very large number of people. Again, back to why we've gone for the 1 dose and then delayed until 8 to 10, 12 weeks for the second dose.
Yeah.
So being vaccinated doesn't allow you to start running around the place feeling that you're able to evade the normal social restrictions that we have now on what you can do, I'm afraid.
And that goes for everyone, not just people shielding, every single person. And kind of just while we're on this point, as Blood Cancer UK and Anthony Nolan, we both know how difficult it is for people shielding. And essentially, some people have been pretty much inside since March last year. And we know how tough that is. So if you are struggling and you are finding it difficult, please do get in contact with our support services team. Both teams have contact numbers that you can call and forums that you can sign up to, and I'll share more details of those at the end of the session. Another question's come in asking about children and vaccination, and whether children will be offered a vaccine, and that's children if they're vulnerable children or just children in general. Jeremy.
Okay. All right. So first thing to say is that the Pfizer vaccine was used in 16 years plus, the AstraZeneca in 18 years plus. Neither were used in children or the data are not yet available for whatever's being done in children. And that makes it a little difficult because we're working with a vaccine that has not really it's not been, the regulatory authorities have said is for adults, essentially. Doesn't stop us using it in children, but the issue there is whether we need to use it in children. And the data we have, I'm afraid, because you're talking about vanishingly small numbers of people, and most of the children who are high risk would have been shielded very assiduously by their family, and therefore would not have been exposed. And that means that we have basically a lack of data about whether COVID is a risk for patients, for children or adolescents with certain conditions, because they basically didn't get COVID during the first wave. Very few of them did. The only signal that we've seen in the data is that children with neurological disabilities do seem to have a high risk infection and mortality, and they have been suggested that they should be vaccinated, although it needs to be discussed with the carer and the medics who are responsible for those individuals. This is close to my home because I look after patients, adolescents with graft versus host disease, and I worry the hell out that they will get COVID and their lung function is so poor that they won't do very well at all. So I think it is possible for individual clinicians, for specific adolescents who have really high risk, that they will get the vaccine. But it's a very small number of people that we're talking about.
Thank you, Jeremy. That's a really, really helpful answer. So another one's come through. So the Prime Minister stated on Monday that he hoped the first 4 priority vaccine groups, which includes people with blood cancer and people who are clinically extremely vulnerable, will have the first vaccine by mid-February. And we got someone asking, what do you think the likelihood of that is?
Asking me?
Yeah.
I mean, that's a slightly tricky question because I'm not very well placed to answer that because it depends on delivery, and that's not something that we in the vaccine committee are closely involved with. I think the answer is, I think there's a pretty good chance that would be successfully delivered. I mean, the numbers are about 2 million a week. That isn't easy, but that's certainly possible to deliver that.
Great, thank you. A difficult question, definitely. But certainly we will hopefully would have made some effort towards getting there by mid-February. If not everyone, we would have definitely tried to get most people done. I just seen a Facebook comment saying my husband is not on the shielding list and he's on chemotherapy tablets for MPN. Should he be on it? And I will quickly take this one and say yes, if he's got MPN, he classifies as a blood cancer, he should be on the shielding list and he should be shielding. And there is a way that we've kind of got instructions on our website that will help you kind of make sure you are on the shielding list, so you're flagged and he's flagged for the COVID-19 vaccine. So I will make sure that one of our support services team gets back in touch with you and helps you do that, because it's very important that he is on that shielding list. So someone's asked, what risks do ET people, which is essential thrombocytopenia, have considering our platelets production and blood clots are found in those who sadly died from COVID? Will kind of our problems with platelets cause problems due to the vaccine? Graham, are you best to answer this one?
I can have a stab. Yeah, so the components of that question, Rachel, just run it past me again.
So kind of considering the problems that people with ET have with their platelets, would there be any issue that you can kind of foresee with the vaccination or even catching COVID?
Right, so the vaccination, no, I don't see any problem with the vaccine. In fact, when we were drawing up our local sort of guideline for vaccine, one question that keeps coming up is, what about low platelets? I mean, essential thrombocythemia, your platelets are high, but what about low platelets? Because there is this concern, if you have low platelets and you give an injection into the muscle, you can end up with very painful hematomas. But actually our clotting doctors were extremely reassuring about that and just said, look, just do it and press on it afterwards. They were very reassuring, actually. They're certainly braver than perhaps some of us felt. Similarly, even people with relatively major bleeding disorders, sure, they should be discussed with their hemostasis, their clotting consultants first, but generally speaking, there are ways in which those patients can be safely given the vaccine. Some people will need some sort of treatment beforehand to help their blood clot better, but those are very rare patients. A central thrombocythemia, that doesn't apply. Platelets are high, or if it's under good control, normal, so that shouldn't be a problem. The question, if you get COVID, are you more at risk of developing blood clots? I think we just don't know. I mean, certainly there is a coagulopathy, so a disorder of your coagulation system that can occur with COVID, and there are clinical trials underway to sort of address that situation. Should we be giving routine anticoagulation to people with COVID? I think the answer is probably not, at least not at treatment doses, but maybe at preventative doses. Whether having ET increases that risk, I think, is unknown at the moment.
Thank you, Graham. One for perhaps Ed, perhaps Graham, perhaps you can do a little tag team. Are there treatments being made that don't involve a vaccine, and what are they, and how might they protect people with blood cancer?
I can start off with that. I mean, yes, there are some preventative strategies as well as treatment strategies, but I'll just focus on the preventative strategies. So there are some anti-spike proteins, so-called passive immunity, where you can actually get administered these proteins as a preventative treatment. These are under trials though, so I'm not aware of any data yet that tells us if they're going to be effective or not. These trials, the trial I'm particularly aware of is basically aimed at people who, for whatever reason, either don't want or can't have the vaccine. So, whether there's a history of severe anaphylaxis, for example, or perhaps after discussion with their consultant feel that the chances of the vaccine working are so small that they may as well not have the vaccine but go on to the trial. However, as Jeremy has said, I think those patients are not common. Most of us would expect most people to derive at least some benefit from having the vaccine. So, if you're given the choice of a trial or a vaccine, most people I would expect would have the vaccine. But those trials are underway. I'm sure Ed would have something else to say on that.
I know, Graham, you've sort of covered a lot of the pertinent information. I think that's the thing of the idea of using passive immunity is one that goes through a whole host of different diseases, not just related to COVID and coronavirus. And there are a lot of companies actually actively seeking to generate these therapies. Obviously, so only a few of them are actually in clinical trials at the moment, but is it a very active area of research that, hopefully for those people who may not be able to be vaccinated, however vanishingly small they are, at least this will then give some hope in the future of some sort of therapy for them to be able to at least have some ability to fight off the infection of COVID.
Thank you both. That's really helpful. Jeremy, I'm going to come back to you if that's okay. And it might be a slightly difficult question to answer, but we like difficult questions. The vaccines, the 2 doses of the vaccines, do we think the immunity that it's going to give us, the protection against the virus that it will give us, do you think it's going to be lifelong? Or do you think we're going to have a yearly vaccine, something like the flu jab?
Yeah, okay. So in our schema, the first plan is to protect as many people as possible. And then we'll come back to this and think about it. And that really depends on there's 2 things to this. One is that we need to know what component of the immune response to the vaccine is protective. We don't know the answer to that question yet. It may seem a bit strange for us to say that, but that is the situation we're in. And then we have to measure that component and see what happens to it over a period of time to get some feel for when, if it wanes. And I suppose if you look at what happens with normal beta coronaviruses, so exposure to the virus, to normal coronaviruses, does lead to an immunity that doesn't last forever. It wanes after a couple of years, seemingly. The data are poor because nobody was ready for coronaviruses before this last year, really, to be honest. But it does look like natural infection doesn't induce protection that lasts forever. Now, vaccination is a much more powerful induction of the immune response, and therefore should last a lot longer, but we don't know how long that will be at this point in time. So I guess if you're going to put me on the spot and really give an answer to this, I'd say I think we will be protected for a good couple of years at least, and hopefully that's enough for this coronavirus, COVID-19, to be put back in its box. But we don't.
That's what we want to see. Teresa, I'm going to come back to you, and I'm going to just ask you, after you had the first dose of your vaccine, did you have any side effects?
No, I didn't actually. I had a bit of a stiff arm the following day, but it was no different from the annual flu vaccine and no other side effects.
I did. I was knackered for the next day. But then also it was the last day of the working year, and I think maybe that just caught up with me rather than the vaccine. It's very hard to associate the two.
So that's actually an interesting question you kind of posed just there, Jeremy. So you're a healthcare professional as well, aren't you? So you've had the vaccine. And so I guess a question is, if people who live with people with blood cancer, they aren't given the vaccine because we don't think it reduces transmission necessarily yet. Why are healthcare professionals being given it? Because you think healthcare professionals are given it to kind of reduce transmission.
Yeah, this is something we went round in circles on, but the bottom line comes down to the fact that healthcare professionals are exposed to a much higher level of coronavirus. The incidence of infection is higher. We worry about the amount they're exposed to, and they also are exposed to a large number of people who are at risk. So if I go into the ward, and if I had coronavirus, I'll do a ward round and I'll be seeing 15, 20 people in that ward round. So the sort of, and there's another component, but I'll come back to it. So I think we think it will impair transmission, and the overall effect of that will be much larger on a healthcare frontline worker than in individuals who live with a single person who's at risk of disease, because we see a lot more people. We also are at risk of disease ourselves. And then the last component, which is becoming apparent now during this second wave, is that a very high portion of the workforce is off because they've either had to shield, not that many people, or they have coronavirus, or one of their house members has coronavirus. And that means that we are suffering from a workforce deficit. And that, when we're going through a pandemic wave as we are at the moment, is a big issue.
Yeah, that makes a lot of sense, and is a really comprehensive answer. And of course, we would absolutely not suggest that healthcare professionals shouldn't get the vaccine. It's just an interesting point. I've just had a couple of questions in the comments about what category people with blood cancer are in, and your priority group number 4. And that counts as anyone who is clinically extremely vulnerable. So you will be in the kind of top 4 groups who were hoping to get vaccinated by the middle of February. Question for Graham, I think, is the vaccination more reactive? Does it make our B cells or our T cells react more?
Oh, crikey. I'm probably not the best placed person. It might be Ed, but my understanding is that it activates both parts of the immune system, but I think that's more one for Ed.
Yeah, I think the data is showing it does really well at activating B cells and T cells to an extent, but obviously for most people it seems the antibody production is very good. So the one thing I think we still are unsure of is it, like as Jeremy said, exactly what is the hallmark of an immune response that allows us to say, yes, we've got protection, yes, we're going to prevent infection or transmission. And at the moment we still don't fully understand that, but we do really appreciate that antibodies and T cells are going to be part of that. It's just knowing what part they play and how strong a role each of those components play.
That makes a lot of sense. I'm going to take the floor for a minute. I'm going to ignore the questions for just a second, because I have a question for all of you, if that's okay, as you are all clinicians. Teresa, I appreciate you're not a blood cancer clinician, and obviously Ed and Jeremy, not specific to blood cancer, but I'm kind of asking this to people. And if you had a patient come to you, or a mum or an aunt, and say, oh, you know what, because of my condition, I'm really worried about getting the vaccine. I'm not sure I'm going to do it. What piece of advice would you give them to reassure them? And Teresa, should we start with you?
I think what I would say is that it's safer to have it than not to have it, and that any level of protection is desirable. And the way I treated it was a bit like the flu vaccine. You know, I remember a conversation with my consultant haematologist a few years ago after treatment about the flu vaccine, and they encouraged me to get it because a level of protection was better than none. So that's what I would encourage people to get it on that basis.
That's a great answer. Graham, would you like to go next?
Yeah, I mean, everything we do in medicine is risk versus benefit. And I'll give you a personal example. So my mother, who's nearly 80, she actually had an extremely rare complication of a flu, well, we think probably of a flu jab that she had about 8 years ago. It's very rare, but quite serious neurological complication. So she is understandably a bit apprehensive about having another vaccine, but the chance of that coming back is very, very small, where her risk, if she were to get COVID, is relatively high. So I'm very much advising my mother to have the COVID vaccine, and she's actually perfectly happy to have it. So, you know, it's risk benefit. The risks of these vaccines to the vast majority of people is tiny, whereas the benefit, particularly for those clinically vulnerable, elderly, comorbid, etc., is really relatively high. So, you know, the default really should be to have it.
Another great answer. Jeremy, what would your answer be?
Well, my answer would be that the trial for the Pfizer vaccine was 40,000 people. There's no strong safety signal. Since that trial, we've had 1 million people vaccinated with the Pfizer vaccine, at least, probably more than that across, I mean, in fact, if you think Israel, I mean, you're talking several million people have been vaccinated with the Pfizer vaccine. And if there was a strong safety signal, we would know about it. There isn't. And if you get COVID and you're over 80, you have a 10% chance of dying. That is a very significant risk. And you know, the relative risk for the sort of the blood cancer group in the 70-year-old, I think, is about 2%, something like that, of mortality if you catch COVID. So compared to a almost negligible chance of a serious side effect, there's no question.
Also a great answer. Well done, guys, for smashing it. Ed, no pressure, last answer.
Thanks. I think I'll take the cop-out answer and just say, actually, yeah, all the previous three answers from Teresa, Graham and Jeremy just sum it up completely. You know, there's the risk benefit, there's the, you know, the likelihood of getting COVID and the complications that you have of that at whatever age it is relative to what the vaccine will give you is negligible in terms of vaccine. And then, you know, with Teresa's point of, you know, even if you suspect that it may not be that great for you to have a vaccine, it may not be as good for you, any benefit is better than no benefit whatsoever. So no matter what you do, just go for it. There's no, you know, for me, I speak to my parents who are, you know, in their late 70s, and thankfully they just see it as, yeah, I just have to have it, because the risk of getting COVID at their age and having serious issues with it is just too great.
Yeah, absolutely. That was really insightful for everyone. Thank you. That's really helpful. I'm just going to pick up on that point of, you know, any protection is better than no protection. Some protection is better than none. We had a question come in asking, actually, what does that mean? What does some protection mean? What does full protection mean? What does no protection mean? And I actually think that's a really interesting point. So, Jeremy, would you like to start with this?
Yeah, I would actually, because I was going to come in anyway on this. So look, if you take flu, everybody's got a reasonable level of immunity to flu. And we get flu because new flu viruses circulate every year. And our immune system to those new flu virus is okay-ish. It has some recognition, but it's not perfect, so you can get flu. The thing about the coronavirus, the COVID-19, is that we have very little immunity to COVID-19, and that is why it is causing such a problem. That's why it establishes severe infection in some people. And in those circumstances, I really probably, and this is proven by the vaccine trials, is that nobody who's been vaccinated, or very few people who are vaccinated, end up in hospital. So it really, a bit of immunity goes a long way for preventing the complications, because we're all starting from a very low base. Our natural immune response to COVID-19 is pretty weak. And as a consequence, the vaccine can kick up a response which is going to be, in almost everybody, are protective enough to prevent severe infection. That's how I view it. I mean, we need more data to be absolutely sure, but that's what I think is the situation with the COVID-19.
So is some protection, does that mean, some protection means you might get the virus and you only have a sore throat, as opposed to losing your smell and taste and ending up in hospital? That's what kind of some protection means.
Yeah, I mean, instead of ending up in hospital on a ventilator, you might be feeling a bit miserable at home for 3 or 4 days. That's the sort of thing.
Yeah, and obviously that is much more preferable as opposed to ending up in hospital. Another question that's come in, I assume neither of the vaccines are live viruses, because we know live viruses cause issues for some people with blood cancer. Ed or Graham, would you like to take this one?
Yeah, I mean, so definitely not. It is important to say that, because there was a little bit of confusion initially about the Oxford one, because, it was a chimpanzee cold virus, I think. But if you look at any textbook about what constitutes a living organism, it really has to be able to replicate. And this virus cannot replicate. It's been completely disabled from replicating. So it should not be regarded as a live vaccine. I'm more than happy for any immunosuppressed patient to get either vaccine. So it should not be regarded as a live vaccine.
That's a really helpful answer. Thank you, Graham. And Jeremy, we've had a question about whether the vaccine is safe for pregnant women.
Okay, so this is another more complex issue, perhaps. The bottom line is, we cannot see how the vaccine can possibly cause a problem in a pregnant woman, because it goes into a muscle in your arm. It doesn't leave that site. Even if it left that site, the components of the vaccine are very unlikely to cross the placenta. And even if they reach the in utero fetus, it's very unlikely they're going to cause any problem. So we cannot see intellectually how there could be a problem. The problem is that there was no data initially with the Pfizer vaccine. We hadn't even got animal studies done at the point when it was first approved, which is why there was a caution at that point in time. I think since then the animal studies have been done and there's no evidence of teratogenicity at all, or harm to the fetus. So that's why the situation has changed. And the advice is now that you can be vaccinated if you're pregnant, but it's a discussion again. It's the sort of risk benefit. If you're somebody who's a very low risk of infection, you may not want to do it. But I think if you were a nurse on a ward working with COVID patients and you're pregnant, you want to be vaccinated.
Thank you, that's really helpful. We've had a couple of other questions come through. We touched on it a little bit earlier, but asking actually, after we've had the second doses of the vaccine, can we request an antibody test? Now, I don't know if you want to come in here. As far as I know, no, you can't request an antibody test at this stage. But kind of as I kind of touched on earlier, Public Health England are running a surveillance project where they will kind of ask people to be part of clinical trials, and will look at the antibody levels and perhaps their T-cell levels following vaccination to see if it's worked. And there is a Pfizer vaccine going on, looking at how a Pfizer clinical trial going on, looking at how well it works in people who are immune compromised, and various other trials going on kind of up and down the country, including one for myeloma patients in Oxford. So as of yet, no, you can't request an antibody test, unfortunately, but we are keeping an eye on all the research that's going on. And if we know of any opportunities, we will, of course, share them with you as and when we know them. Does anyone else have anything they want to come in on?
So it is variable where you live. I mean, I hate to say it, but we can request it here in Oxford. But we're very aware that we're quite fortunate that we're able to. With those caveats that I mentioned earlier, that there are 2 different antibody tests, and it's got to be the right one if you want to detect a response from the vaccine. But you certainly can't go to your GP and ask for one. That's just not a service that's available.
That's useful to know. So I guess speak to your clinician as well and see what they can do. A question has come in saying, I assume the kind of overall feeling of the panel is that this vaccine is safe for people with blood cancer. So Ed, I will come to you to answer this one, and maybe if you can just kind of touch on the differences between safety and effectiveness, that would be really helpful.
Yes, so as you've mentioned before, the number of people who were in the clinical trials for these vaccines was, in the tens of thousands, and there are a very limited number of adverse reactions, of which, there were common side effects to many of these types of vaccines. So I think from a safety point of view, there isn't, there's so many people have had it now, like in the millions, as you were saying before, in Israel, where we haven't seen any major adverse side effects at all. And by now we would have seen them. So I think, from that side of things, I'm fairly confident, if not completely confident at all, that it is safe to have. It's not going to cause any issues with people who have it. And if there are going to be issues, those patients will probably already be known to the medical teams that they could potentially have adverse reactions, such as those who have severe allergic reactions, etc. And so, to make a vaccine effective, it has to show that it's doing the job that it's supposed to do. So we know from the clinical trials that depending on the vaccine, you can get somewhere from, the Pfizer was somewhere like 90% effectiveness in terms of achieving a notable immune response in those patients, and compared to, say, the Oxford vaccine, which was, depending on the dosage, was somewhere between 60 to 90%. So I think from my point of view, it is completely safe, these vaccines, and they are effective at what they do. And more so than perhaps many other vaccines that we know, these vaccines are under a huge amount of scrutiny from the public, rightfully so. And so the data that is supporting these vaccines has to be held up to the highest standards, and they are showing that they are effective at what they do.
Thank you, that's really helpful. Now I'm going to kind of finish up with one final question for probably both Jeremy and Graham, and that is there a kind of preferred vaccine for people with blood cancer to have? Is there a preference between the Oxford vaccine or the Pfizer vaccine? Jeremy, shall I come to you first?
Yes, short answer, no.
Great, Graham?
Completely agree. And I mean, I'd be interested, can I ask you actually, Jeremy, because you've looked at the trial data in much more detail than me, I'm sure, but as a hematologist and as a clinician, we're always warned against comparing results from two different trials. And we often hear that, the Oxford vaccine was 70% overall, the Pfizer was 90%, but I was a participant on the Oxford one, and we had to do asymptomatic testing every week. I don't know if they had to do that on the Pfizer one. So, can you say one is more effective than the other, the 70 versus 90, or can you just not?
There are differences between the trial, and it makes it quite hard to compare. The actual end result, the primary endpoint for both trials was symptomatic PCR positive. So the swabbing that you were doing was a different subsection of the trial, and that's about transmission, or trying to identify basically where it affects asymptomatic disease. But
if it was positive, I might sort of think, oh yes, that's snuffly nose, and maybe I've had a headache or a slight fever. I don't know,
Yeah, you're absolutely right, because the symptoms that they're talking about, you could probably have, randomly, and in fact that's true. The control group had anyway, fine. So a lot of the people who are PCR negative had symptoms. Yeah. So I think the efficacy, there's a lot of emphasis, especially amongst Americans, again, bigging up the Pfizer versus the AstraZeneca. But I think what will happen as it all washes out with larger numbers is that the differences between the two will become closer. They won't be so marked, I suspect, in the efficacy. And really, the efficacy we really want is prevention of disease that causes you to end up in hospital or kills you. And I suspect both will be equally efficacious at doing that. But it will take a very large number of patients subjects to be vaccinated before we have some good data for that.
Thank you, that's really helpful. We have hit 6:30, so I will bring things to a close. There have been 352 comments on Facebook, so apologies to those of you who we didn't get to, but as I say, someone from support services will kind of go through the comments and come back to you. They're going to have a very busy day tomorrow. I'm sure they'll be pleased to see. Just a big thank you to all of our panelists this evening. You're getting a lot of love in the comments. You can't see them, but I can. People really appreciate you taking the time for being here and answering their questions. You've all done amazing jobs. Big thank you to Anthony Nolan for partnering with us on this. Thank you to the British Society of Immunology who helped us find Ed, our lovely panelists, and a big thank you to the JCVI and our friends at the Department of Health who helped set this up. And the Department of Health have been really helpful answering some of the questions we've had as well. So yeah, a big thank you to them. If you'd like to kind of stay in contact with us and kind of get the latest updates on vaccines, you can sign up to our e-newsletter, and there should be a link at the top of the Facebook chat bar. What I will say is if you enjoy the session, you are in a position to, please donate to the charities that mean a lot to you. It's a very difficult time for charities at the moment, as it is for everyone. But if you have enjoyed this session, we'd really appreciate any donations. And as always, we know it's a really difficult time for people with blood cancer at the moment. And if you are concerned, both Anthony Nolan and Blood Cancer UK have support services. So you can call Blood Cancer UK on 0808 2080 888. And you can call Anthony Nolan on 0303 303 0303. But yeah, that's it from me. Thank you so much everyone for joining us on Facebook. We hope it's been a useful session. And if you'd like more of these sessions in the future, please let us know and we'll be able to set them up. But apart from that, have a lovely evening everyone, and see you soon.
Right. Bye everybody.